So I have the pleasure to introduce our first speaker, Dr. Seun O Falade-Nwulia. She's an associate professor in the Division of Infectious Diseases at the Johns Hopkins University School of Medicine. Her research focuses on understanding barriers to viral hepatitis, HIV, and substance use disorder care uptake, and the use of implementation science approaches to improve viral hepatitis, HIV, and substance use disorder treatment services for people who use drugs. She's also an active provider of viral hepatitis, HIV, and substance use disorder care.
Thank you so much for the kind introduction. Okay, so it's a tough act to follow that panel, but I will do my best. I want to start by thanking the conference organizers for the opportunity to come and share some of the work I have been fortunate to do with others to advance equity in hepatitis C outcomes. So here's the title of my talk. These are my disclosures. So all of us have been hearing about this charge to eliminate hepatitis C as a public health threat. And the way we're going to do that is by treating 80% of people with chronic hep C. The way we will know we have achieved that is because we will have a reduction in new infections by 90%. And this will translate to a reduction in mortality by 65%. Unfortunately for us in the US, and I imagine here in Canada too, there are many populations that continue to be left behind. This is data looking at prevalence by race and by other socio-demographic characteristics in the US. You see in the first column that overall prevalence of hepatitis C in the population is 1%, with higher prevalence of 1.8% among Blacks, and even higher prevalence of 10% amongst people that are homeless or incarcerated. The very last column is even more depressing because we continue to see increases in incidence of hepatitis C across these populations when you look at 2021 compared to 2015. A lot of this in the US is driven by injection drug use. The first plot is data from the CDC showing rates of incident hepatitis C between 2007 and 2022. And what you see across all age groups are increases in incident hepatitis C. In 2022, we were so excited for the first time. We saw a dip in incidence. Unfortunately, this is not across all populations. Most of this is driven by urban areas with increasing incidence in some rural areas of the United States. Even more depressing is the increase in overdose deaths. The plot to your right shows overdose death. In the US, over 107,000 people died an avoidable death in 2022. And so as we reflect on what the gap is, we have a high hepatitis C prevalence in disadvantaged and vulnerable populations. We have these amazing drugs that are associated with high rates of cure, but limited uptake of treatment. We heard about the multi-level barriers just now on the panel. System barriers of limited hepatitis C and treatment locations, and the fact that very often the places where hepatitis C treatment is available are not the places that the communities routinely access services. In the US, we continue to have restrictions in hepatitis C treatment coverage that remain a significant barrier. We have limited number of hepatitis C providers, and we just heard about how stigma continues to impact the way providers provide care, which also impacts the willingness of individuals to come and receive care. For our patients, there's limited health information where many people still do not know that hepatitis C is a treatable disease or that they have hepatitis C. Anticipated stigma from prior experiences with the healthcare system, enacted stigma from current experiences, and internalized stigma continue to be a significant barrier to hepatitis C treatment uptake. For us in the US, and I imagine here in Canada, we also have an incredibly fragmented healthcare system, which for populations that already have competing priorities of trying to feed themselves, house themselves, or address their drug use, it makes it literally impossible to access care. And so how do we advance equity in hepatitis C care outcomes? The CDC gives us some pointers, We need to increase awareness and education across all groups. We need to expand access to testing and treatment. We need to meet people where they are, and we need to reduce stigma. I'm going to talk about some of the work we've done in Maryland to try to address this. The map you see is a heat map which shows hepatitis C prevalence across the counties in Maryland. So like all heat maps, the lighter colors are lower prevalence areas and the darker colors are higher prevalence areas. The Baltimore City is right in the middle there. It's a high prevalence area, and then you have rural counties. So this county, for context, is a 4-hour drive from Baltimore City. The Transporting Hepatitis C Viral Elimination Services via Telemedicine travel program, very cute, if I say so myself, was implemented by the Johns Hopkins Viral Hepatitis Center in 2018. And this was realizing that we had this area pretty close, but not close enough, right, with a high prevalence of hepatitis C, and providers in Baltimore that had the expertise to treat and cure people of their hepatitis C infection. And so we implemented a blended model where we have telemedicine provided by remote clinicians who are sitting in Baltimore. We had a nurse in Allegheny County who was the face of the program, who met people and had the discussions with them, and also provided case management around the other social determinants of health that might impact their engagement with care. And then we also had remote pharmacy support. We still require prior authorizations to access hepatitis C treatment in the state of Maryland, and so that's really critical. The pharmacy also provided adherence support to patients. In the first 6 years of program implementation, we have had 504 patients referred to the program. I'll share that most of those patients have actually been referred in the last 3 years. It always takes a while for a program to get up and running. We see that the median age of our participants is about 42. It's a predominantly white population, and I'm proud of the percentage of women we are serving through this program at 41%. I would also like you to note the prevalence of substance use disorders at 61%. So this is a local health department. It's not a syringe service program. And this speaks to the co-occurrence of hepatitis C and substance use, which we need to think about addressing together. As you can see, it's very low tech. That is all the tech we need to implement our program. So we have a computer or an iPad, which is linked to a computer screen so that the patient can see the provider. And then we have our nurse sitting next to our equipment. These are hepatitis C treatment outcomes. We have 504 patients that were referred to the program. We see that once we are able to get patients to complete their treatment, we consistently see high rates of engagement through completion of treatment, rates of engagement above 90%. However, we see a drop-off. But when patients come back for their cure labs, essentially everybody that comes back for their cure labs achieves hepatitis C cure. And so what we see is this drop-off, right? At that initial phase of linkage to care, which we've already heard about, some of that is being able to access confirmatory viral load testing. And then again, on the back end, where patients have completed treatments and we need them to come back for assessment of SVR12. We're really looking at availability of rapid HCV RNA testing, which is finally approved in the US, to hopefully help us advance progress in these steps in the care continuum. The other thing that we're very excited about is that our outcomes are equally good for our patients regardless of whether they have a substance use disorder diagnosis. We see that in the first column where we have patients with a substance use disorder diagnosis, 100% attended the provider visit. Majority initiated treatment, majority completed treatment. Now again, the drop-off is confirmatory blood work. But amongst those that come for confirmatory blood work, we see that essentially everybody achieves cure, which is similar to what we see in our patients without substance use disorder diagnosis. I shared with you about the co-occurrence of hepatitis C and substance use. We have tools that can treat substance use disorders. The first plot shows data from a trial where patients with opioid use disorders were randomized to no medications for opioid use disorders versus buprenorphine or methadone in the two lines below. A couple of things to point out, that over time, we see that patients who are on methadone or buprenorphine have significant reductions in their substance use. Reductions in substance use improve health outcomes. And we also see that these reductions in substance use also translates to prevention of hepatitis C infection. Oh man, this funnel plot shows us that patients that are on buprenorphine or methadone have a 50% reduction in incident hepatitis C, which I believe also translates to reduction in reinfection after treatment and cure of hepatitis C. And so we have these tools. What do we do with these tools? Our next program is a program called Access Telehealth, and this really was a collaboration where we're working with the Maryland Department of Health, the syringe service programs that are supported by the Maryland Department of Health, and the Viral Hepatitis Center at Hopkins that provides expertise in hepatitis C program implementation and treatment. We sought to integrate hepatitis C and opioid use disorder treatment via telehealth across syringe service programs in Maryland counties. People with lived experience are a critical component of our multidisciplinary team, and we sought to leverage the SSPs, which are a trusted source of service provision for people who use drugs. From the very beginning, we wanted to know about implementation outcomes, so we used the AIM, IAM, FAME tool to assess implementation outcomes. It's a scale that goes from 1, completely disagree, to 5, completely agree. And what you see is that when we brought this program to the sites, they said, we think this is highly acceptable, we think it's highly appropriate for our population, and we think it's going to be feasible for us to implement. Our partnership has helped us to implement the program in a way that it has the highest potential for sustainability. So we started by identifying and preparing champions. We did some training, and we had a strategy to engage participants. We assessed existing services and care infrastructure at the SSPs. The strategy to implement was decided on together by the SSPs and our site, so that for each SSP, the program is a little different because we are adapting to context at the SSPs. We install telemedicine infrastructure, and that we also make sure that our opioid use disorder and hepatitis C services fit into the workflow of the SSP, because that increases the likelihood that it will be sustained long term. In addition to preparing champions, it was important that we train the SSP staff. They needed to know what hepatitis C treatment was so that they could explain this in ways that the community they were serving understood. We needed them to understand how buprenorphine worked, right? So they could talk about buprenorphine in ways that made the SSP clients more willing to engage in care. Our peers have been critical to ensuring that patients engage in care. We continue to provide ongoing technical assistance, and over time, we monitor implementation. We didn't just implement and stick with the initial implementation plan. We've continued to adapt to context over time. We started with just 2 SSP sites. Within 3 years, we had expanded to this 1, 2, 3, 4, 5 SSP sites. Now we're at 8 SSP sites. And so the program is doing well. The SSPs are talking to one another, and everybody wants to come on board. Please note, we are not providing any incentives to anyone for any part of this work that I have shared with you. Our philosophy is to provide patient-centered care. We use motivational interviewing. We have a harm reduction framework, and provide buprenorphine to treat opioid use disorder and hepatitis C treatment. And it's always been a collaboration between the SSP, ourselves, and our Maryland Department of Health partners. Here are our initial outcomes from the first 3 programs that we had. We had 281 patients referred to the program. Median age was 39. Again, it's a predominantly white population, consistent with the population in rural Maryland. 48% of the people we're serving are women. Again, really advancing equity in access to hepatitis C treatment. And when we look at this plot, we see that across the stages of the care continuum, 92% of patients attended their appointment, of which 90% initiated hepatitis C treatment, 80% completed DEA treatments, and a similar theme where we have a significant drop-off with confirmation of viremia. But everybody that came to get their SVR12 assessment achieved hepatitis C cure. So again, another place where we're looking to implement rapid HCV RNA testing to close this gap in the care continuum. Very excitingly, the re-entry programs in the local communities where we're providing hepatitis C treatment are also taking notice, and we've begun to do some in-reach to provide hepatitis C treatment via telemedicine in the local jails through these programs. I'm going to talk very briefly about our work evaluating integration of hepatitis C treatment into opioid treatment programs. So we all know that people who use opioids who are in these programs go there sometimes every day to get their methadone or buprenorphine. In the rapid hepatitis C study, we sought to assess effectiveness of on-site hepatitis C testing and treatment with peer support at OTPs, and we compared it to what is still standard of care in the US, which is linkage to specialist hepatitis C care. The study was a hybrid effectiveness trial. We used a randomized control trial design to assess effectiveness and worked across 5 OTPs in Baltimore, Maryland, Birmingham, Alabama, San Francisco, California, and Toronto, Canada. The study was funded by AbbVie, so we had access to GP for all our patients. The intervention included, 1, identifying champions at the OTPs. We provided technical assistance. Each site had access to a local hepatitis C treatment specialist who worked with the OTP site to help them designate who their hepatitis C treater would be. Each site also identified a person with lived experience of hepatitis C who was a patient at the OTP. We then provided training to that individual to become a peer who supported other individuals that were randomized to the intervention arm through their hepatitis C journey, focusing on supporting them to initiate treatment, adhere to treatment, and teaching them skills to prevent reinfection. The off-site specialty referral arm was linked to the local specialist at a university site. They had appointment facilitation where if they called a number, they were guaranteed an appointment within 2 weeks. The primary study endpoint was hepatitis C treatment initiation. Our secondary outcomes were time to initiation and SVR12, and we also assessed for safety. Here's the study population. We see that our population had a mean age of about 48, 58% were white, high rates of unemployment at 42%, 30% had been homeless in the prior 6 months, high rates of anxiety and depression symptoms at about 40%. We see that majority of patients were treated with methadone, and majority of our patients still had substances detected in their urine at baseline at 67%. Here are our big outcomes. If you look at the folks that got on-site treatment with peer support, 89% initiated treatment. Those that were referred, 21% initiated treatment. I know for those in this room, everybody's like, yeah. Well, but it's good to see it, right? When you look at time to initiation, the folks in the rapid hepatitis C arm had a significantly shorter time to initiation at 19 days versus those that were referred to specialist linkage at 53 days. If you look at SVR12, intervention arm SVR12 rate of 61% versus SVR12 rate of 14%. So please note that a significant proportion of these individuals did not start treatment, which really is the key. We need to get people initiated on treatment so that they can achieve cure. When we focus on those that initiated treatment, SVR was similar in both the intervention and standard of care arms. And when we focus on those that initiated treatment and actually came back for evaluation of SVR, we again see similar rates of cure amongst individuals that were treated by OTP clinicians and those that were referred to a specialist for care. With regards to appropriateness, across patients and staff, we saw high appropriateness reflected in the comments from the qualitative data. A patient said, "So I thought it was just convenient. It was perfect timing." Yeah. Perfect timing. Another said, of peer support, "I thought peer support was wonderful because she had already been through what I was going through." An OTP staff member said, "I think this should be standard of care. Way more patients got connected to care, way more patients got treated, and also leads to less fragmented healthcare." An OTP counselor said, "It made this process a lot easier for both me as a counselor and a patient." With regards to acceptability of peer support specifically, a client said, "It makes a big difference. It's not just some little thing. It's definitely like noteworthy, and it's stuff like literally, just like a single text exchange could settle some uneasiness in me. Getting that reassurance coming from a place where I feel it's genuine and just not like some textbook response. Well, there was some difference of opinion where another OTP client said, I wasn't a huge fan of the peer support. My peer guy was fabulous. I loved him. He was a great guy, but it started to seem very redundant about halfway through because I didn't have any side effects. Again, maybe speaking to a need for individualized care. And staff member who is also a program manager and clinician also noted high acceptability of the peer support, saying that he felt like improved stigma. What I don't have on this slide is some quotes related to feasibility, where the OTP staff did say that while they thought this was appropriate and while it was acceptable to be able to sustain this intervention, they felt like they would need more support to be able to routinely integrate hepatitis C treatment into what they do. I'm going to end by sharing some data from our Bartlett Clinic and really kind of thinking about micro-elimination. We come to these meetings and we see this huge goal and we're like, oh my, how are we going to get this done? But I do think we need to think about micro-elimination. Let's piece it out. In our HIV clinic in Baltimore, we serve about 3,000 patients. The plot you see is one of HCV viremia. So in the dotted line is across everybody living with HIV in our clinic population, and the solid line is amongst those that were antibody positive at any point in time. And what you see is that in 2009, across our clinic, the hepatitis C viremia prevalence was 36%. By 2021, our hepatitis C viremia prevalence is 2%. Thank you. I wish I could take credit, but a lot of that credit goes to Dave Thomas and Mark Solkowski, who have been leading that clinic for decades. They had a plan, they shared the plan with everybody. Everybody knew their roles. The clinicians knew they were supposed to treat. There was a system for easy linkage. The nurses provided case management. And for patients that had issues with insurance, we had ways to address the barriers to their hepatitis C treatment. And that is why we have this success. And the way that I hope everybody feels confident that this really is an effect of treatment is that when you look at those that were antibody positive, right, amongst antibody positive people, prevalence of viremia in 2009 was 76%. In 2021, prevalence of viremia is 6%. Now, what's happening with our disparities? Okay, 2009, right, we had many disparities. Our clinic population, as you can see, again, predominantly male. It's predominantly African American. A high proportion of the clinic acquired HIV through injection drug use. In 2009, we had disparities by gender, disparities by age, disparities by race, disparities by substance use. With expanding access to everyone, we see removal of majority of these disparities. No disparities by gender, age, race. But unfortunately, we continue to see disparities for our people who use drugs. And this is a population that we will continue to need to think about strategies and put efforts into advancing equity. In conclusion, I hope we all agree that disparities in hepatitis C treatment outcomes persist, despite availability of highly effective hepatitis C treatment. Increased uptake of hepatitis C treatment is feasible through implementation of targeted strategies. HCV integration into community-based settings has potential to address disparities and address elimination efforts. It's going to be critical that we continue to monitor progress, implement strategies to meet the needs of all populations impacted by hepatitis C. I have so many people to thank. The amazing folks I work with at the Center for Substance Use and Infectious Disease Care Integration at Hopkins. In particular, I want to recognize the amazing nurses and nurse practitioners I work with to implement our telemedicine programs: Tracy Agee, Sherlyn Brickley, Tricia Ticknell, Jackie Bickner. I want to recognize Mark Solkowski, who has been such a champion for a lot of the work I've shared today. our patients, the amazing people who use drugs, who contribute to our work, both by providing their perspectives, which we use to develop strategies, and then give us feedback on how we're doing or not doing well. Collaborators, mentors and mentees, and funders of this work, and especially all of you for listening to me. Thank you so much.
Thank you. I think we have time for one question. Brian.
Thank you for being here as an American. We like you. If you want to see a comedy video, look at what just happened at the White House. Look at the break. I'm going to ask you the same thing I kind of asked you in San Diego. This is heroic work, and you've saved lives, and it's fantastic. It's that 61% SVR rate, in your intervention arm in the rapid cohort. 61% is 39% short of 100. Is there what can we do to get at the other ones? Is it a technical artifact? Is there something we can do?
Yeah, so part of that 61% are the 11% who didn't initiate treatment at all, right? And then even for those that initiated treatment, as you could see, this is a population with high rates of homelessness, many competing priorities, which make it challenging. I think we just need to continue to meet people where they're at, meet their needs. I suspect that some of what we're seeing is reinfection, address reinfection, but I think 61% is a lot better than 14%.
Yes. Absolutely. Absolutely heroic.
Thank you very much.